Thank you and good morning. I would like to briefly introduce you to the connection between inflammation and arterial stiffness. Before we start, I would like to apologize that this is not something I am terribly familiar with. So there might be some information that are lacking or not explored fully. So the arterial stiffness, as explained by the previous speakers, can be measured by the pulse wave velocity, which is essentially just a measure of how fast the waves are traveling in the arterial walls. So as the aorta is a conduit vessel for the pressure generated by the left ventricle, ideally, as you can see on the right-hand bottom side, that the normal artery would absorb the pressures generated by the left ventricle and create a more even pressure by the time it arrives at the target organs. But when the arteries become more stiffer, the waves would not be absorbed and travel at a much faster speed. So the pulse wave velocity, which is distance divided by time, would increase in stiffer arteries. And this aortic stiffness can damage load resistance organs via excess arterial pulsatility. So high pulse pressures can damage the end organs. And some of the more vulnerable organs, as you know, include the kidneys, the brain, and the heart. These are some of the effects of a stiff aorta on the heart. On the left-hand side, we have decreased myocardial perfusion in the stiffer aorta, myocardial fibrosis, LV hypertrophy, and myocardial dysfunction. And so as a consequence, increases in aortic pulse wave velocity is very closely related to increased risk of adverse cardiovascular events. So an increase of 1 meter per second in aortic PWV correlates to around 15% increase in MACE. Previously, inflammation was not regarded as a strong factor in terms of vascular remodeling, but in the past few decades, chronic low-grade inflammation has been reported to be a central active driver of pathological vascular remodeling, which results in increased arterial stiffness. So in particular, a key molecular pathway that has been linked to vascular atherosclerosis is the NLRP3 pathway, which stands for not LRR pyrene containing protein 3 or something like that. So this is a group of proteins that can switch the inactive interleukin-1 beta pro form into its active form by the caspase-1, which is an enzyme that cleaves off the pro form to the active form. And this sets off an inflammatory cascade of reactions that results in upregulation of other inflammatory markers such as interleukin-6 or CRP or PAA1. The CANTOR study was a landmark study that showed how control of inflammatory markers can result in improvements in cardiovascular events. So here, the targeted blockade of interleukin-1 beta by the monoclonal antibody canakinumab significantly reduced MACE, but upon subgroup study on the right-hand side, the effect was relatively limited to those who had additional downstream blockade, if you remember from the previous slide, of interleukin-6, as well as the targeted interleukin-1 beta. So various mechanisms can increase the stiffness of the three arterial structures, as you have seen in the previous slides, the intima, the media, and the adventitia. And among these mechanisms, there are many ways the inflammation can affect the vascular stiffening process. So one of the most prominent mechanisms is the reduction of nitric oxide production by the endothelium, and lack of nitric oxide in the vascular wall results in poor relaxation and oxidative stress. And these also play a role in vascular smooth muscle cell regulation, or, as you can see on the right-hand side, which affects the stiffness and tone of the arterial walls. And the smooth muscle cells themselves become transformed into a pathologic form under the influence of cytokines, which makes the arterial wall stiffer. So here you can see that these cytokines orchestrate a pro-stiffening environment through several downstream effects, most notably the dysregulation of the extracellular matrix, the ECM. They promote the expression and activation of the matrix metalloproteinase, MMPs, and these act to degrade the elastin fiber network and activate the TGF-beta and so on, creating a disorganized array of stiff collagen fibers that displace the previously healthy and compliant vessels. And these are some of the examples that inflammatory molecules which can cause arterial walls to be stiff and non-compliant. These are not separate mechanisms, but rather are a chain of reactions that can influence each other interconnectedly. So amid speculations that showed some associations between inflammation and arterial stiffness, whether inflammation actually caused vascular stiffness was not certain until 20 years back, when researchers from Greece demonstrated a cause and effect relationship between inflammation and arterial stiffness. So they randomized 100 healthy participants into those who received vaccination for typhus and those who did not. And they also put these participants into two groups of study. And the first studied the pure effect of vaccination on the aortic stiffness and ray reflections. And the second study wanted to look at whether anti-inflammatory agents such as aspirin can do something about it. So this is a result. And in study one, after vaccination, just after 8 hours from vaccination, the aortic stiffness measured by the pulse wave velocity and the augmentation index increased significantly, as did the inflammatory markers of CRP, interleukin-1, and MMP9. And in the second study, these were the patients who received aspirin before taking the vaccinations or the placebo controls. The effects of vaccination on the pulse wave velocity were relatively cancelled out by the aspirin treatment. So the pulse wave velocity were not different between the vaccination and the control groups. But it is interesting that the inflammatory markers did still increase in the vaccination groups. So these were mechanisms by which vessels become senescent as we age. And do you notice how similar they are to the previous slides, which showed effects of inflammation on vascular walls? So aging has similar effect as inflammation on the damaging of the vascular walls. So this observation has coined the term of accelerated vascular aging, as also explained in the previous presentation, or some call it inflammaging, as a combination between inflammation and aging of the vascular walls. And naturally, it was demonstrated in many clinical studies that arterial stiffness increases in various chronic inflammatory diseases, most notably the lupus, rheumatoid arthritis, psoriasis, inflammatory bowel diseases, and arterial stiffness was increased in almost all of these patients. On the other hand, treatment with anti-inflammatory agents in these patients have shown to improve arterial stiffness, including the anti-TNF-alpha therapies and also statins and ezetimibe, which we will look at later. So the evidence so far from these diverse clinical scenarios reveals a clear dose-response relationship. And as you have seen in the randomized trial of vaccination, high-dose inflammation from a vaccine causes a sharp transient increase in stiffness that returned nearly to baseline after around 1 or 2 days. And in contrast, the chronic low-dose inflammation in the chronic diseases people, like RA and psoriasis, led to a progressive increase in stiffness over time, where the cumulative inflammatory burden, aka the disease duration, is a key determinant. Again, this is a brief summary of evidence that chronic inflammation contributes to accelerated vascular aging and vascular stiffness. And several cornerstone cardiovascular therapies exert their benefits in part through anti-inflammatory mechanisms that are independent of their primary mode of action. These were also shown in the previous presentations very nicely. So RAS blockers, ACE inhibitors, and ARBs, and statins are drugs which were primarily developed for other uses, namely hypertension and dyslipidemia. But these have also shown other independent anti-inflammatory effects which act to reduce vascular stiffness. Anti-inflammatory agents, by definition, act to reduce inflammation, especially targeting autoimmune diseases. So TNF-alpha therapy, colchicine, these can also significantly improve arterial stiffness. Lifestyle interventions, again, these are well-known interventions that can lower blood pressures as well. These have been, it's likely that exercise and diet have some connections with arterial stiffness, which may or may not be the predecessor of hypertension. So doing these lifestyle interventions in patients with chronic low-dose inflammation can also help decrease vascular inflammations. And so the most promising anti-inflammatory agent or pathway for cardiovascular effects so far involve the interleukin-1 pathway, as was shown in the CANTOS trial. The interleukin-1b pathway emerged as a validated and highly promising target for cardiovascular therapy. But the more important side of the CANTOS study is that the degree and extent of inflammation should be approached individually as in a personalized medicine, because patients with similar baseline profiles showed different responses to the interleukin-1 blockade depending on whether interleukin-6 was also blocked. So since the advent of the CANTOS trial, many other trials have taken place to assess the blockade of interleukin-1 for cardiovascular benefits. So these are some of the studies that studied the effects of anakinra in STEMI, non-STEMI, and HFrEF patients. So pathophysiologically, coronary artery is also an artery which is susceptible to inflammation. So blockade of interleukin-1b should ideally be beneficial for diseases involving the coronary artery. So various degrees of stable coronary disease, MI, and ischemic cardiomyopathy involving cardiac remodeling, interleukin-1 blockade has been shown to be beneficial in various stages of these models. And there are also other pathways, as you have noted from the CANTOS trial as well, which show promising outlook for the amelioration of MI, such as the interleukin-1 pathway. So to summarize, inflammation is a central, causal, and modifiable mechanism in the pathogenesis of arterial stiffness, and the assessment and management of vascular inflammation should be considered an integral part of treatment of chronic inflammatory diseases and cardiovascular disorders. And finally, targeting inflammation should involve personalized approaches. Thank you.